Hi, Mr. Lane. My name is Nicole Reckard. I'm a CSU and BPA student. I'll be conducting your exam today. Is that okay?
Yes.
Great. I'm just going to wash my hands. And while I'm washing my hands, I'm making sure I'm observing my patient's general appearance and status. I'm observing for if they're awake, alert, and responsive, that there are no apparent distress, and they're well developed and well nourished. If any of the vital signs are abnormal, I will make sure that I will repeat them. So we're also going to start with our mental status exam, which is also part of that general appearance as well, that making sure they're alert and oriented ×4. Mr. Lee, do you know where you are today?
Yes.
Where are you?
I'm at the hospital.
Do you know what day of the week it is?
Wednesday.
Do you know the day of the week? That's the same thing. Do you know the date? Excuse me.
Today's the 10th.
The 10th of
March.
And what are we doing today for you?
Eye exam.
Okay, and can you state your full name?
Morgan Lane.
This guy's sicker than we thought.
Great. Thank you, Mr. Lane. We're also going to make sure we're doing an eye exam. So everything's going to be from the neck up today. So when I'm performing my skin exam, I'm just going to untie the back of your robe here just to look at that upper part of your shoulders. So I want to make sure I get proper exposure, and I'm looking at the skin for any areas of pallor, cyanosis, any rashes, bruises, lesions, dryness, ulcerations, maybe some sweating or diaphoresis. And then we're going to be noting the head exam. I'm looking at his head for size, shape, any evidence of trauma. So we're looking around. We can be touching and palpating as well for any kinds of depression, any kind of bruising or tenderness. I'm looking at the face for any kind of asymmetry or any involuntary movements, expression and edema. And I want to look at the hair distribution. So he has a beard, so we're looking at making sure there's no loss in the distribution also of the eyebrows, and making sure they're symmetrical. Excellent. So we're going to move on to the eye exam. I'm going to be looking at the eyelid, the conjunctiva, and the sclera. I'm going to gently pull down both your eyelids if you don't mind looking up for me. Good. And we're looking for making sure there's no injection, jaundice, erythema, excuse me, or any kind of foreign body, or exophthalmos, which is proptosis, which is when the actual globe is kind of pushing out of the socket area, or any kind of an eyelash direction. So making sure the eyelashes are nice and out, nothing's going in, or they're kind of curving out towards the surface as well. I'm going to look at the cornea, the iris, and lens for any opacity. So I'm going to be using my pen light. Mr. Lee, would you mind looking straight ahead for me? We're coming at about a 60 degree to the tangential lighting. So we're kind of coming on the side. I'm looking for any kind of those opacities or graying or blurriness of the cornea iris area. Perfect. I'm going to look for the corneal light reflex. So this is looking for the position and alignment of the eye. So I want you to look directly at my nose, Mr. Lee. I'm going to shine a light about 12 inches from him, right in the center, and I'm looking for where the light is reflecting off of the center of the cornea. It should be in the same position on either side of the eye. And that's looking, again, for the position and alignment, and that looks great. If it was malaligned, then we have to think about strabismus, or in layman's terms, like a lazy eye, where some of the muscles can be weakened. I want to make sure that I'm going to do my cranial nerves. So, Mr. Lane, do you wear contacts or glasses?
No.
So using my Rosenbaum chart, I'm going to hold this about 14 inches away from your nose. I want you to read the smallest line possible, okay? And I've measured my forearm from my wrist to my elbow. That's about 14 inches. So it's approximately right here. With both eyes, can you read the smallest line for me?
372846.
Perfect. Can you cover your right eye, please? Now with your left eye, can you read it?
372846.
Perfect. Okay, cover your left eye. And read it backwards, please.
648273.
Okay, thank you. So he was 2025 OU and in the right eye and 2020 in the left. Okay. Next, we're going to do visual fields by confrontation. So I'm observing for any kind of visual deficits. So I want you to look directly at my nose. We're going to be staring at each other. I'm going to be moving my fingers in 4 different areas of your vision, and you're going to let me know what number you see while continuing to look at my face. Okay?
Okay.
So tell me what number you see.
2 1 2 1.
I And you want to kind of keep it between the both of you because you're testing your peripheral vision against your patient's peripheral vision. Now I want you to cover your right eye. So I'm going to cover my left eye so we're in the same peripheral vision here. Again, what number do you see?
1, 2,
Okay.
1,
And rotate it so you
2.
can still see it. So I can, this is just on my periphery so I can just tell. So he should be able to do the same. And cover your right eye, your left eye, excuse me, I'm going to cover my right eye. And the same thing.
1, 2, 1, 2, 1.
Perfect.
Okay.
Okay. And you see he kind of like, just because of the angle of crossing over, sometimes repeating it is okay, making sure that we're all getting that accurate. If there's a discrepancy, we got to do the referral for a better eye exam. Okay? All right. So next I'm going to be kind of moving the eyes around and checking the pupil reflex. So again, take a fixed spot on the wall and be shining a light in your eye. So I'm shining it in the left eye, I'm looking for the direct response. And then I'm shining it in the left eye and looking at the right eye, looking for the consensual constriction of that pupil. And the same thing on the right side, direct response and consensual. Excellent. I want you to look at my finger and then I want you to look at the wall. Look at my finger and look at the wall. Perfect, look at my finger. So I'm making sure that we have good constriction of both pupils when we're looking at the near object and that it dilates when we're looking at the far away area. And that's testing for accommodation. And the last one is for convergence. So I want you to follow my finger with your eyes and we're just bringing it close together, making sure symmetrically they have fluid movement towards the center. I then want you to follow my finger in an H pattern. We're testing your extraocular movements, which is cranial nerves 3, 4, and 6. So follow me in all areas of direction. And we're looking for symmetrical fluid movement in the 6 cardinal directions. Perfect. So I'm also looking and inspecting for ptosis or ptosis, however you like to say it. So that's looking for any kind of lid lagging or drooping. And when we're looking at the eyelids before, we're also inspecting for that. So right now I don't observe any kind of ptosis. Okay. Now that we've done the external exam of the eye, we're then going to be looking the internal exam. So we're going to do form a fundoscopy. So we're going to shut the lights, grab my ophthalmoscope, making sure it's on the large, bright circle, and the front aperture is actually on the X. It helps with the comfort of the shining light in the back of the retina. So if I'm going to be looking in his left eye, I'm going to be using my left eye. So my left hand, left eye, I'm going to be using my right hand to support his eyelid up with my thumb. Okay, so we're coming in. We're looking for a red reflex. We'll be coming in pretty close. Excellent. And we're moving together so I can see the arterial veins. We're looking at the disc. And we're moving as one unit. Perfect. Nudge it blank a little bit. And on this side. So again, I'm going to be using my right eye to inspect his right eye, using my left hand to lift the eyebrow up. Looking for the red reflex. Lifting it up. Perfect. Now we're looking in all the areas, looking nasally, looking down. Good job. Thank you. Don't forget to turn the lights back on. And while I was doing that, I was looking at the disc, retina, and vessels. For the disc, I was looking for if there's any pallor around the disc, clarity of the borders, and for papilledema. The retina itself for color, hemorrhage, cotton wool spots, and exudates. And looking at those vessels, the arteries and veins for nicking, neovascularization, microaneurysms, and wiring. Now there are 4 special techniques I want to go over. If my patient was complaining of any kind of eye discharge or redness or swelling at the lacriminal sac, which is kind of just the medial canthus kind of down here, I want to make sure, touch my face, wash my hands real quick. So I want to be looking for any kind of nasolacriminal duct obstruction. So all it is I'm going to have you look towards the right here, and I would just gently press towards the medial canthus down the apparatus. And the same thing on this side, look that way. And I have them look away just because you'd be touching really close to the eye, and we're putting a gentle squeeze. So if I'm pressing here and I'm getting more discharge coming out of the punctate of the lacrimal apparatus, then there could be an obstruction of some sort. If my patient was complaining of severe eye pain, that something was in his eye, it feels like there's a scratching, and we would also perform a fluorescein staining, but we'll learn that in technical skills. I need to be able to evert his eyelid because sometimes a foreign body can actually get stuck underneath the eyelid, and every time he blinks, it could scratch the surface of the cornea. So what I want to do is actually grab the Q-tip. So what I'm going to be doing is I want you to look ahead and down just a little bit. I'm going to be placing the Q-tip tip right here on your eye. I'm going to be grabbing your eyelashes a little bit and flipping it up to look under. You okay with that?
Mm-hmm.
Okay. So what we're doing is gently holding here, look up for me, grabbing the eyelids, and we are averting the eyelid. Perfect. Just like that. I'm sorry that's uncomfortable. But if we don't look under there, then we're going to be missing a foreign body. The next one is the swinging flashlight test. So this is looking for an afferent pupillary defect. Now the afferent response is the light going into the eye, which is for cranial nerve 2, the optic nerve. So what I'm looking for is making sure there is no sluggish response, or when I'm shining a light inside the pupil, it should constrict. In an afferent pupillary defect, sometimes it can dilate. So I'm going to be going back and forth. Look at my nose. I'll be shining a light in either eye, kind of going back and forth. So I'm shining it here. I should see constriction. I'm looking for both direct and consensual each side. Constriction, constriction, both sides. Constriction, constriction. Perfect. So if there was an abnormal response, then I would see when I direct my light into the affected eye, it would only cause a very mild constriction or a potential dilatation of that eye, noting that the afferent reflex or the response from the light could be damaged. The last special test is called the cover-uncover test. This is looking for strabismus that may not be really noted when we're just looking, we're just observing our patient we initially saw. So I want you to cover your right eye for me and look ahead. Okay, then I want you to uncover it. Same thing here. Cover it, we're observing the eye that's uncovered, making sure there's no deviation of the eye, and then uncover. So we're looking for if there is any kind of lag. So say when he uncovered his left eye, if the eye was actually looking laterally, it would then go back into the normal gaze if there was any kind of strabismus. So this is just trying to challenge those eye muscles when we're not having any kind of visual stimulation. All right. That concludes our eye exam. The next video is going to be on our HEENT exam as well. Thank you, Ms. Ryan. I appreciate it.
Cut!